Good evening, everyone. We are in third day of Cytokine Release Syndrome Conference. I again welcome all the faculty members and the delegates who have joined for the third day of this event. So we had two very successful days. So we went through different syndromes and situations where cytokine storm is seen, especially in critically ill children. And we had wonderful talks from the experts worldwide and a great participation from all the delegates. We hope the last day we have a similar engaging participation. And I would request all the participants to send their questions and continue their engagement through Q&A box. With that, I hand over to Dr. Chandrika to introduce our chairpersons for today.
So good evening, everyone, and welcome to the third and the final day of the symposium. It's my pleasure to introduce our chairpersons for the first session. Dr. Pala Ramachandran, he's currently the head of Department of Intensive Care and Emergency Medicine at Kanchi Kamakoti Child's Trust Hospital in Chennai. He was the chairman of the Intensive Care Chapter of IAP in 2010. He's a member of the Accreditation Committee of the College of Pediatric Critical Care. He has numerous publications and has written 30 book chapters and delivered over 170 invited lectures nationally and internationally. So welcome, sir. Dr. Bhaskar Shenoy, he's the head Department of Pediatrics and the chief of Pediatric Infectious Disease Division at Manipal Hospitals, Bangalore. He has been adjunct professor of pediatrics at Manipal University and coordinator of the ID Fellowship Program. He is the honorary secretary of IAP ID chapter for the year 2022 to 2023. He has been the joint secretary of Indian Society of Kawasaki Disease and the national coordinator for dysbiosis, PCART vaccinology and ultra modules. He's the managing editor of Pediatric Infectious Disease Journal, editor-in-chief of Karnataka Pediatric Journal, honorary IMA professor of pediatrics, and he has several papers in national and international journals. He's the editor of books on infection control and grand rounds PID. He was awarded the Dr. P.C. Bopaya Endowment Lecture by IAP BPS, the Professor Gopal Das Oration at IAP Odisha, and Dr. Nabendu Chaudhary Oration at IAP Burdwan. So welcome, sir. And Dr. Suma Balan is a professor in pediatric rheumatology at AIMS Kochi. She did her qualification from JIPMER and following which she trained in UK. She has been the past chairperson of the Pediatric Rheumatology Society in India. So welcome, ma'am, and over to Dr. Bhaskar Shenoy to introduce our first speaker. Thank you.
Thank you, Dr. Rakshay and Dr. Chandrika for a nice introduction and giving the opportunity. Now we'll directly go to the first session. The first session, the speaker is Dr. Surjit Singh. Of course, he needs no introduction, but as a formality, I have to say a few words about him. He is the head Department of Pediatrics and chief of Pediatric Allergy and Immunology Unit at Advanced Pediatric Center, JIPMER, Chandigarh. He is the director of Asia Pacific League of Association of Rheumatology, Center of Excellence in Rheumatology, Chandigarh, and he is currently the president of Asia Pacific Society for Immunodeficiency. And he is the first person to start the DM course on clinical immunology and rheumatology. And he has been nominated as a member of Institute Body of AIMS Raipur. He has given he has been awarded with several orations, especially from Hong Kong and Singapore, the Levinsky Memorial Oration and the Stuart Gann Memorial Oration. The honors are lots, and of course, he is the associate editor of International Journal of Pediatric Rheumatological Diseases. He is advisory board member editorial in Clinical Immunology Reviews, and he has been the director of National Coordinating Center Pediatric Rheumatology International Trial Organization, Printo, Gano, Italy. He's been the visiting professor from in BP Koirala Medical College, Nepal, and even Kasturba Medical College, Manipal, and Shanxi Provincial People Hospital at China. He has been awarded with the ICMR awards 2 times, and many awards to his credits. He has given many orations by the professional society. He has been into the administration also as the Deputy Director of Administration at AIMS for some time and Chief Vigilance Officer, and he was the joint medical superintendent also. So with that, I request Dr. Surjit Singh to deliver his talk, Suspecting Immunodeficiency in the Eye of Storm. Sir, the stage is for you.
Thank you, Dr. Bhaskar. So I shall be speaking on immunodeficiencies in the context of cytokine storms. As we have been hearing over the last 2 days, this is a very complex clinical situation that any pediatrician can be ever asked to manage. And as our knowledge increases, as our investigative workup gets further refined, we now realize that there are several syndromes that can present as a cytokine storm. And one major group of conditions that can present in this way are primary immunodeficiencies. So I would be restricting my talk basically to the presentation of primary immunodeficiency as a cytokine storm. So I should be touching the pathogenesis very briefly because this has already been discussed at length over the last 2 days. I shall be giving an overview of the primary immunodeficiency diseases in the context of a cytokine storm. And of course, these days, the correct terminology is inborn errors of immunities, or IEIs. Some real life case scenarios that we have been involved in. And lastly, when to suspect IEIs in a patient with a cytokine storm. So very briefly, the pathogenesis of the cytokine storm. So as we all know, in a normal individual, there is a very delicate balance between the activated CD8 cells and the macrophages. And as a result of this balance, the viruses get killed, but the immune system doesn't go overboard. What happens in patients with HLH is that this balance between the activated CD8 cells and the macrophages goes haywire, and as a result, there is continued expansion of activated lymphocytes and macrophages, which results in tissue damage. So this is the long and short of the immune basis of HLH. So what are the IEIs that we encounter or that we can encounter in a patient with cytokine storm? So I have broadly classified these under 2 heads. One is the group of syndromes that we call primary HLH, or familial forms of hemophagocytic lymphohistiocytosis. And the other group would be IEIs other than primary HLH, and that is again a very long list. So primary HLH, this is a group of conditions in which there can be a very severe cytokine storm. This condition was first recognized almost 60 years ago by a group of workers, and this was identified in 1952, and they had given the terminology hemophagocytic reticulosis. Of course, at that time, they had no idea about the pathogenesis, and they had no idea about the cytokines that were being released in this syndrome, in this condition, but they just identified the clinical syndrome and noted that it had a very poor prognosis. Even till the 1990s, very little was known about this syndrome. And I remember in 1990, we had done a collaborative study between patients with HLH at the Great Ormond Street Hospital and the King's College Hospital in London. And we had collated our data from the 2 hospitals, and we realized that majority of these patients had died. At that time, even this was not known that with a bone marrow transplant, you can salvage some of these patients. In fact, it was after this study that the British Pediatric Surveillance Unit got together a set of hospitals in the UK, and they started treating these patients with hematopoietic stem cell transplantation. Primary HLH results from genetic defects in natural killer cells and cytotoxic T cells, and the common pathways involved are the perforin and the intracellular vesicles. Several treatment regimens have been used for this condition, but majority of the patients would not survive unless we give them a stem cell transplant. We now know that there are at least 8 genetic variants that can present with a primary HLH. And amongst these, the common ones are the ones related to perforin deficiency. Perforin deficiency, the monk gene defects, but many others can also present in a similar manner. The phenotype is largely similar, and you can pick up these disorders, majority of these disorders, only after you have done the genetic analysis. Of course, disorders like Griscelli and Shediac-Higashi syndrome would give you some phenotypic features, but this is not true about all patients and about all types of these syndromes. So the genetic defects result in problems with the immune response at various levels. This could be at the level of sorting, polarization, docking, priming, and fusion. But the end result is the same, and that is an unbridled immune response resulting in the cytokine storm. So I would give you 3 cases. These are all real life cases, and that we had the occasion to manage. The diagnosis was not straightforward in any of them, and we were not in a position to diagnose these cases in the initial few days. It was only later that we diagnosed them. So this was a 6-year-old boy, resident of Shimla, who presented with fever for 6 days, poor weight gain, yellowish discoloration of eyes, and rash. So when you encounter such a patient in the pediatric ER, the differential diagnosis can be very wide. These were the petechiae that he had over the abdomen. Physical examination showed severe pallor, icterus, petechiae, and ecchymosis on the trunk and legs. And systemic examination showed a very prominent hepatosplenomegaly. Investigation showed severe anemia, thrombocytopenia, decreased neutrophil counts, raised triglycerides, and a low fibrinogen and a very high ferritin. So there were enough grounds to suspect an HLH after we had the initial investigative workup done. Bone marrow showed hemophagocytic lymphohistiocytosis, and flow cytometry showed that the perforin expression was reduced on the CD56 plus NK cells. Genetic evaluation showed 2 pathogenic variants in the perforin gene. The second case was a 9-year-old boy. Again, note the age. The first case was 6 years old. This was 9 years old. So it's not necessary that all familial HLH patients would come in early infancy. So he also presented with fever, headache, vomiting, joint pain, had multiple hospitalizations for these complaints. Physical examination showed hepatosplenomegaly, and investigation showed anemia, thrombocytopenia, a high CRP, a high erythrocyte sedimentation rate. Ferritin was raised, there was low fibrinogen, triglycerides were elevated, and there was some elevation of the transaminases. Serum immunoglobulins were essentially normal. Perforin expression on flow cytometry was normal, and the ANA was negative. The next generation sequencing panel showed a hemizygous mutation in the XT-XBP2 gene. So he was diagnosed to have familial HLH, managed with steroids and cyclosporin, and parents were counseled for stem cell transplantation. The third case was relatively younger, 2.5 years old boy, fever, abdominal distension, and 1 episode of seizures. Physical examination showed moderate pallor, generalized adenopathy, and hepatosplenomegaly. Investigation showed anemia, thrombocytopenia, high CRP, a raised ferritin level, low fibrinogen, raised triglycerides. So enough evidence on the hemogram to suspect an HLH, provided one is keeping this in that differential diagnosis. Serum immunoglobulin assay was normal. The lymphocyte subsets initially showed some presence of B cells, but after treatment, when we with rituximab, when we repeated it, the B cells became virtually absent, as was only to be expected. So this patient also had normal perforin expression on NK lymphocytes. The next generation sequencing showed a hemizygous mutation in exon 3 of the XIAP gene. So these three patients had different genetic defects, but the investigative profile and some of the clinical features were largely similar. So he was diagnosed to have XLP2 with HLH, managed with IV pulse methylpred followed by oral steroids and cyclosporin, to which he showed a prompt response, and patients were counseled for stem cell transplantation. After 2 months, he had recurrence of the features of HLH. He showed Epstein-Barr virus VCA positivity and a very high EBV viral load. So he was diagnosed to have EBV-triggered HLH, given rituximab at 0 and 2 weeks, along with pulse methylpred. Presently, he's on cyclosporin, and he has been initiated on IVIG replacement because of the hypogammaglobulinemia secondary to the rituximab. So when does one suspect and evaluate for primary or familial forms of HLH in patients with cytokine storm? Of course, whenever you have a very early age of presentation, this will be the setting where you must think of the primary forms of HLH or the familial forms of HLH. But as I just showed you, all three patients in this that I have taken were older than 1 year of age. So it's not necessary that they will present always. Familial forms of HLH will always present in infancy. If the family history gives some clues, for instance, a similar illness in the other siblings or consanguinity, that is another important clue. Patients who have had recurrent infections in the past, or patients, for instance, like Shediac-Higashi syndrome or Griscelli syndrome, that have pigmentary abnormalities, and of course, presence of a hypogammaglobulinemia would be suggestive of an underlying HLH. But in majority of the patients, you would not be able to pick up this syndrome based on clinical findings alone, and you have to resort to a prompt and extensive investigative workup. The problem is that there are several other inborn errors of immunity that can also present with a cytokine storm. And based on our own experience, this is our experience of patients with severe combined immunodeficiency in whom a cytokine storm was very prominent. So in this series of severe combined immunodeficiency from our center, we had 6.3% patients with severe combined immunodeficiency who had evidence of HLH. And the mean age of onset of clinical symptoms was 4.25. Now, this is an incredibly difficult, clinical setting. You have a patient who has a major immune deficiency like severe combined immunodeficiency. On top of that, he develops HLH. So not only is the diagnosis very difficult, but the treatment would be again very, very difficult, because you would have to think twice before using immunosuppressants in these patients. This is another set of patients with cytokine storm, and this is with chronic granulomatous disease. In this patients, 5 out of the 80 patients at our center had evidence of HLH. 4 had X-linked CGD, while 1 had the NCF2 defect. And in 2 children, HLH was the predominant presenting manifestation of CGD. So the clinical presentation can sometimes be very, very tricky, and you have to have a very low threshold, not only for diagnosis of HLH, but also for CGD, to be able to pick up such tricky presentations. And the infectious triggers in these patients, of course, included the typical signature organisms for chronic granulomatous disease, that is Candida albicans, Burkholderia, and Francisella. 3 out of these 5 patients who had HLH, they had succumbed, but 2 we were able to salvage. So HLH in the context of a primary immune deficiency disease can be a diagnostic nightmare, and one has to be very careful while managing these patients. Apart from these 2 immune deficiencies, there are several other immunodeficiency disorders that can be associated with a cytokine storm. And many of these disorders, it's not easy to diagnose them based just on flow cytometry. You have to resort to genetic diagnosis. And if these immune deficiencies are further complicated by an HLH-like presentation, one can imagine how difficult it can be for the clinician to decipher the clinical and the laboratory profile. And it's no wonder that it takes a lot of time, sometimes weeks together, before you can understand what is happening. With the genetic tests being more readily available now in our country, that has helped us a lot, and we can now pick up some of these conditions much more easily than was the case around 5 years ago. So what I would like to emphasize is that a whole spectrum of inborn errors of immunity can be associated with HLH, and some of the common clinical settings where you can get HLH are the immunodeficiencies associated with Epstein-Barr virus infection. And there again, the clinical presentation can be very tricky. So this is our investigative workup, how we manage these patients when we suspect HLH on the basis of fever, splenomegaly, thrombocytopenia, and hyperferritinemia. You would do a bone marrow aspirate first. You would look at the other clinical findings. You would do flow cytometry. And then, of course, for majority of the patients, you would end up doing a genetic analysis. So to conclude, pediatricians should have a low threshold for diagnosis of HLH. Clinical presentations can be diverse, prompt, and detailed investigative workup is crucial. The initial therapeutic interventions often need to be made on clinical grounds alone, and hematopoietic stem cell transplantation may be the only option for HLH associated with the inborn errors of immunity. I must acknowledge the help of our senior resident, Dr. Reva Tyagi, for this presentation. Thank you very much.
Thank you, sir. Thank you for that wonderful eye-opening this thing. In fact, we always think of HLH in a infection, in the background of infection. But this is another area wherein we need to be more alert and look at the HLH. In fact, it is of course, it has sensitized the viewers about the thinking of the HLH. And there is a question, sir. Can you correlate the type of mutation and infection trigger? Was the questions.
Yes, for several of these immune deficiencies, there are what are known as signature organisms. So, for instance, for chronic granulomatous disease, you would often have organisms like Candida, Aspergillus, Serratia, Burkholderia. So, whenever in a given clinical setting you identify these Staphylococcal aureus, whenever you identify these so-called signature organisms, you would think of that particular immune deficiency. But when this immune deficiency has a concomitant HLH associated with it, on the bedside, it may look very easy to give this presentation, but on the bedside, the decision making can be very tricky. And the problem is that you don't have enough time. The investigations are not easy to arrange. So you have to really rush with the workup. And as I said, the initial therapeutic protocol that you would unleash would be based on your clinical judgment. And using immunosuppression in the context of a primary immune deficiency, is not always a very comfortable decision. But if you delay the suppression, the result is very grim. Any correlate immunosuppression in HLH in presence of infection trigger that I have covered. The third question is HLH in IEI is precipitated de novo or precipitated by infection. Both, it can be precipitated by infection as well as de novo. Are these patients at risk of which signature? The last question.
Are these patients at risk of HLH only with the signature organisms or with any other organism?
No, they can be at risk with any organism. Is infection always associated? I'll say it is usually associated, but not always. How do you decide steroids 2004 protocol if primary is associated with infection? Now, this is tricky. We don't always use the 2004 protocol in patients with primary immune deficiency. We generally would confine ourselves to steroids and generally not use the complete 2004 protocol because that can be very toxic in these patients, and the complications associated with the 2004 protocol can sometimes be more difficult to manage than the HLH itself. So generally, if you get HLH in the context of a PID, I think our major stress would be on steroids, either methylprednisolone or dexamethasone, along with cyclosporin.
Sir, do you have any preference of methylprednisolone over dexamethasone in these cases?
Well, it is said that dexamethasone is preferable because it has better CNS penetration. So some centers prefer using dexamethasone. We generally would use methylprednisolone because in high doses, say 30 milligram per kg, methylprednisolone also has reasonable CNS penetration. Any role of IVIG? IVIG is usually given in these settings where the HLH is associated with the primary immune deficiency disorders.
Any etoposide has any role, sir?
As I said, we are reluctant to use etoposide in these patients. We are generally reluctant to use etoposide because of the toxicity associated with it.
Dr. Bala has some questions, sir.
Yeah. Thank you, Dr. Sujit. My question is regarding the ferritin level in these patients. Typically, what we have been told is that in HLH, your ferritin levels will be very high, over 10,000, etc. But these patients had a relatively much lower level, 2,600 in that range. Your comment on that, please.
Yes, you're right. You're right. In familial HLH, usually the ferritin levels are very high, but the cases that I am showing you, these are all real life patients. The diagnosis was not made, in the first few days. It's only later that we were able to make the diagnosis. So the real life scenario can be quite different from what is given. You're right. You're absolutely right that the ferritins were not very high.
But is ferritin the only thing? Because other parameters also we have to look at.
Yes, ultimately, ultimately, what we have realized is that the earlier you do the genetic tests, better it is for the patient. And with the clinical background investigative workup, you can only do so much. But the clinical presentations can be very heterogeneous. There can be big overlaps. And some of the most difficult situations that we have encountered, in fact, right now, at this time, we have a patient with EBV associated HLH, and that can be a real diagnostic nightmare. So Epstein-Barr virus in context of primary immune deficiencies associated with XIAP or other syndromes can be very, very difficult to manage.
So you had tested these children with the next generation sequencing. You mentioned the panel, NVT8 panel or something like that. We normally, when we do genetic testing, we send either a whole exome or a clinical exome sequencing. What is the difference between these two?
We have access to this panel, and this can be done free of cost. That is the major advantage. And the bioinformatics support that is available with the invitee panel is very good. So when you're suspecting a PID, you can do this limited panel because it covers more than 500 genes. And since the bioinformatics support is much better with the invitee panel, so we prefer doing this. And of course, it can be done, gratis. So that is a major advantage that we have for our patients.
I think the time is up. Dr. Chandrika, do you have any time, or can we? Dr. Chandrika, can we go for the next session, or do we have time?
I think we can take another 1 or 2 questions.
Yeah, anybody? Any other question?
Dr. Singh, what's your turnaround time for the genetics?
Usually a few weeks.
Yeah.
Usually a few weeks.
Yeah. Okay. Any experience with emapalumab, sir?
No, we haven't. We have never used it. What about you?
No, sir. We were trying to get it for a patient, but it was too late. I think Chandrika recently has experience. How she got it, it would be interesting.
Oh, no, I haven't used emapalumab as yet, ma'am. Not yet. Thank you, Surjit Singh, sir, for that amazing lecture.
Thank you very much. Thank you very much.
And
Thank you, sir.
Dr. Shenoy, sir, for chairing the talk. I now request Dr. Pala Ramachandran to introduce our next speaker, please.
Good evening, everybody. It's my pleasure to introduce Dr. Rakshay Shetty. Rakshay Shetty is one of the most active and enthusiastic members of the pediatric intensive care community in India. He did his MD at PGI Chandigarh, and then he subsequently trained at Sick Kids in Toronto. He holds an FRC PCH, and he's a fellow of the International College of Critical Care Medicine. He is currently the head of Pediatric Intensive Care Services and Academic Director of Pediatrics at the Rainbow Children's Hospital in Bangalore. He's a founder member of PD Stars India. He's been previously he's been a board director of the International Pediatric Simulation Society. He has a fellowship in point of care ultrasound from the American Ultrasound Leadership Academy. He has done several simulation workshops all over the country. He's an invited speaker all over India and in many international conferences. He has several publications. His areas of interest are critical care physiology, point of care simulation, and critical care sonography. Raksha is going to be speaking to us this evening on the many phases of cytokine storm in critically ill children.
Thank you, Mr. Bala, for a very kind introduction. I hope my slides are visible.
Yes.
Yes.
Okay. All right. So I'm going to talk next 20 minutes on cytokine storm in PICU. Now, like last couple of days, we've been discussing about cytokine storm. And I think one of the great challenges when we talk about cytokine storm is, do we all agree what cytokine storm actually means? And we had a wonderful debate on day one. And there was a lot of conflict in terms of what actually each participant or each faculty is talking. Do we actually mean the same? So that's the difficult part of cytokine storm. And I think, especially for us intensive care community, and our studies are filled with negative results, purely because of the fact that we have not been able to define conditions properly. Now, whether be it sepsis or be it with ARDS, we've had our challenges with regards to defining a condition. Now, with cytokine storm 2, I think that's a challenge. And I think going forward, in terms of reporting our results or communicating, we need to have better understanding what we actually mean by cytokine storm. So this publication, which came up in NEJM, I think kind of nicely summarizes what they actually mean by cytokine storm. So, cytokine storm essentially means that you have elevated circulating cytokine levels. You have an acute systemic inflammatory symptoms, and along with that, you have a secondary organ dysfunction. Now, that could be beyond that, can be attributed to the pathogen if a pathogen is present. Now, we also saw yesterday in on the first day, Dr. Scott Canna's talk about this diagram of cytokine storm syndromes. Now, this is a syndrome, which means we need to understand this a bit more carefully. Like you gave an example of shock. I think it's a very wonderful example about how should we think about cytokine storm. Now, let's imagine a child comes in shock in ICU. Now, we don't treat all shocks in a similar way, correct? So we think, okay, is this a cardiogenic shock? Is it a septic shock? Is it a hypovolemic shock? And then our therapy depends upon what kind of shock we're dealing with. For example, in cardiogenic shock, we don't give fluid bolus. We might start with epinephrine directly. In septic shock, we might start noradrenaline early. In hypovolemic shock, it's predominantly fluid therapy. So giving vasopressor support for hypovolemic shock or giving a fluid for a cardiogenic shock might have a detrimental outcome. So in a similar fashion, I think we need to understand what actually this cytokine storm means. So what essentially tells is that there's an inflammatory state in the body, which is harmful to the host. And that inflammatory state is not very helpful in clearing the infection, but it's actually harming the host. And there could be multiple pathways that can happen. And it's important to understand each of those pathways, because the therapy and how to intervene, when to intervene, potentially depends upon the pathway we are talking about. So technically, if I were to talk in ICU, almost majority of the patients whom we see should actually have a cytokine storm. So there is no reason why a septic child should land up in ICU if he's able to fight his infection appropriately. So in ICU, we could essentially say that majority of the reasons why we see cytokine storm is related to sepsis, and that forms the bulk of our condition we see. And then there are various other conditions like trauma, burns, pancreatitis, liver failure, which could cause cytokine storm. We had a couple of wonderful talks yesterday describing what a localized cytokine storm means, whether limited to brain, to the liver, to the pancreas, or to the lungs. And there's a lot more work is happening in those fronts where there might not be systemic inflammation, but a significant local inflammation, which allows the disease to persist. So let's look at the pediatric sepsis data. Now, what we know is a severe sepsis, the mortality can go upwards of 20%. And what we also know is that, especially when there's a multi-organ dysfunction, now the current standard of therapy is we give antibiotics, we give supportive therapy, we treat shock with vasopressors, We do a lung protective ventilation. We manage the fluid balance to keep it less than 10%, and we focus on nutrition, and we hope the patient recovers. That's the whole focus of our therapy. What we know is patients who die in less than 3 days when they develop sepsis, it's generally because of refractory shock. And once they die beyond 3 days, it's because of multi-organ dysfunction. So technically, like I just mentioned, we treat all multi-organ dysfunction literally the same. Now we know the sepsis definition. It means you have an infection, but then infection is associated with the immune dysregulation. Now, immune dysregulation or immune dissonance is what we call a cytokine storm, and that clinically we recognize by organ dysfunction. Okay, so the pattern of the organ dysfunction will probably depend upon whether it's a bacteria or virus. And oftentimes in ICU, we see gram-negative organisms. We see toxic shock syndromes because of staph or strep. We see rickettsial fever presenting with cytokine storm and various viruses. And we all know how dengue can cause a problem. And we had a discussion about how influenza can cause. And right now, we're in the middle of adenovirus epidemic with lots of children developing necrotizing pneumonia, some with myocarditis, some with shock, and many of them, and some of them landing up on ECMO. So what I'll do is I'll just quickly go through a case. We had an interesting case discussion yesterday, which is a very similar case to what we had yesterday. So this is a 6.5-year-old child presenting with pain in the right wrist and a restricted movement. Child was treated with paracetamol. Fever lasted for 24 hours, but then subsequently had pain abdomen, vomiting, and the wrist pain resolved. The lab showed thrombocytopenia with platelet count of 60,000, WBC of 5,100. Dengue test was negative. The fever recurred on day 5. The labs done on that day showed a rise in CRP, rising up to 115, with a normal count being less than 6. The liver function tests and our renal function tests were normal. COVID RT-PCR was negative, and this was during the COVID pandemic. We had this child, and the Vidal was negative. Child was treated with antibiotics outside, and then they repeated a test next day, and the platelet count became even worse, dropped to 24,000. And then we saw some evidence of third spacing in the form of gallbladder wall edema, pleural effusion, and ascites. Child received a platelet transfusion. Child was in altered sensorium and subsequently was transferred to us. So essentially, at that point in time, we thought about septic shock, we thought about dengue, about MIS-C and rickettsial fever as a differential diagnosis. At admission, if you were to look at this lab, the CRP is quite high, 114. We also see that the liver functions are deranged now. The renal functions are deranged now. The WBC count has gone up. Platelet count has dropped to 22,000. We see there's significant lactic acidosis. We see the serum ferritin level elevated to beyond 2,000 level. D-dimer levels are high. Pro-BNP is high. LDH is high. And the COVID serology, IgG, and even dengue ELISA, IgG comes positive. The ultrasound done at our center showed bilateral pleural effusion, hepatosplenomegaly, gallbladder wall edema, and ascites. The CT brain was normal. So at this point in time, these were the summary of the situations we faced: febrile encephalopathy, leukocytosis, thrombocytopenia, high CRP, normal ESR, high ferritin, high LDH, liver and kidney injury, cardiac dysfunction, and COVID serology positive. So child was treated initially on 3% saline infusion, antimicrobials, and since the sensorium was worsening, child was intubated. And within 4 hours of admitting to ICU, we gave the child methylprednisolone, and neuroprotective measures and non-invasive neuromonitoring continued. In view of worsening renal parameters, we started the child on dialysis. And by 96 hours, we noticed new onset purpura with a falling platelet count and falling hemoglobin. This was the image of that child. So we thought this was thrombocytopenia-associated multi-organ failure phenotype. And we continued mechanical ventilation. In view of TTP kind of a picture, we gave a double volume exchange. Subsequently, post plasma exchange, child became hypertensive. Child underwent few more sessions of plasma exchange till the platelet count recovered. And then dialysis was continued for 4 more days. And subsequently, by around day 7, child was extubated, off renal replacement therapy, off a plex, and a platelet count recovered. During this period, we covered the child with antibiotics and continued on weaning dose of steroids. This is how the course actually evolved. So we see the platelet count recovering to 1.2 lakhs, and we see the hemoglobin stabilizing over time. So by day 10, the child was discharged and sent home. So this is one of the, I'm sure the participants who are attending here, these are the cases what we normally see, and just goes to show on to the fact that cytokine storm is not something we see unusually. It's something we see commonly. Now, this is an important diagram for us to understand about what happens in sepsis and why is it different from many other conditions. Now, what we see initially in first couple of days is an intense pro-inflammatory state where there's immune activation predominantly dominated by interleukin-1 and TNF-alpha. Now, then there's a yin yang. So to control the inflammation, there has to be anti-inflammation so that you reach immune homeostasis. Now, that often happens through interleukin-10. Now, unfortunately, in those patients who develop multi-organ dysfunction, the immune suppression part becomes very intense to the point that it just doesn't recover. So you land up in a state what we call as immune paralysis. Now, this immune paralysis, if it stays for a longer time, it leads to macrophage activation. And in the next few slides, I'll explain why that particular thing happens. And oftentimes, this macrophage activation manifests in the form of high ferritin levels. So what is so peculiar about cytokine storm we see in sepsis? And in what way the hyperinflammatory state we see in sepsis is different from, say, primary HLH or even rheumatological mass? What's the difference? The difference is that in this condition, because of immunoparalysis, we see that NK cell levels tremendously deplete, and the lymphopenia, the T cell count depletes. So these two things are extremely important. What happens in primary HLH for that matter is the NK cell, there is a perforin granenzyme pathway deficiency, but there's a lot of T cell stimulation, and that T cell stimulation drives interferon alpha levels, and that interferon alpha is one thing which causes macrophage activation. Because he has a depletion of NK cell and T cell, the interferon levels become very, very low. And because the interferon levels are very low, they find it very difficult to clear the infection. So they have a way of macrophage activation which happens through inflammasome, and that's completely independent of interferon gamma. And why this is important for us to understand is because the therapeutics. So we had a wonderful debate between Dr. Scott Canna and Dr. Ashish. And Dr. Ashish did point out that when they treated patients with adenovirus, they had a poor outcome. And why labeling patients with a particular name becomes a problem. Now, when we call them as HLH, and we go to the HLH-based protocol of management, which involves drugs like etoposide, for example, it focuses on T cell depletion. Okay, the idea is to deplete T cell, decrease interferon gamma, and decrease macrophage activation. Now, unfortunately, that's not what works in sepsis. You already have a depleted T cell, interferon gammas are already low, and giving etoposide can actually be hazardous in septic shock. So using this primary HLH protocol could be deleterious. And that's the reason probably what he said in his discussion, that if you give that therapy in patients, say with adenoviral patients with hyperinflammation, you would have a detrimental outcome. So this is again a cartoon and the image to say what happens to the N cell activity. When you're faced with the bacterial sepsis, the NK cells switch from high cytokine producing to a low low viral cytotoxicity profile. So they move from low to high cytokine producing and a low viral cytotoxicity. Now, unfortunately, patients who land up in immunoparalysis state, this low viral cytotoxicity remains. The NK cell number becomes quite low, which means you find really, really hard to actually clear viral infections. And that means there could be late reactivation of viruses, even in bacterial sepsis. It's important to understand this, that even in the bacterial sepsis, there can be late DNA viral reactivation like adenovirus and a few other viruses. And that can actually drive up the ferritin. So this point is really important for us to understand. And that's something we should always evaluate at the bedside. Now, similarly, what happens is with even the T cell. The T cell lymphopenia can happen, and that is something we can always see in our blood reports too, that the lymphocyte actually drops. And there are lots of autopsy studies done in septic patients who had HLH. When they did the biopsy of the lymph nodes in the spleen, they found that, and even the thymus, they found there's a completely depleted lymphoid tissue. And again, this lack of T cell stimulation of interferon gamma to macrophages means that you don't clear this viral infections clearly, which means there is a reactivation. And finally, you have macrophage activation. The macrophage activation, what we see in sepsis, generally has this phenotype. They present with hyperferritinemia, hepatobiliary dysfunction, and DIC as its dominant feature. So this is again a cartoon and a table which goes through how the hyperinflammation differs across various conditions. And like I said, the NK cell and T cell activity significantly reduces in bacterial sepsis compared to other conditions. Now, when people try to understand about why these patients, some of them land up in multi-organ dysfunction, what we understood is that there are two systems in the body which significantly multiplies multiple fold. One is the cytokines and other one is cytochrome P420 metabolic system. What happens in those who develop cytokine storm is not only they multiply their cytokines, unfortunately, the cytochrome P250 metabolic system becomes very weak. It does not multiply, which means you'll be unable to clear those metabolites. Now, in the phase of pathogen-associated PAMs and DAMs, proteins, there can be significant stimulation, which leads to significant amount of cytokine production. And that coupled with your reduced cytochrome P450 system means these are going to injure our epithelial system, which manifests in the form of cholestasis and hepatobiliary dysfunction. It can cause renal tubular injury, which can manifest in the form of AKI. It can damage lungs, and that can manifest in the form of ARDS. If it affects endothelial system, that is what we see in the form of thrombotic microangiopathy. You have thrombosis, microvascular thrombosis. It can cause mitochondrial dysfunction and immune cell dysfunction, like what we just mentioned, where there is a lymphoid depletion and impaired microbe killing. So Dr. Carcillo and his group, they try to understand to see whether we can, if we evaluate all the cases of MOTS, whether we can understand and identify clinical phenotypes which have a different pathogenic mechanism. So when they did their analysis, they described three systems. One is immunoparalysis associated multi-organ failure, sequential multi-organ failure, and thrombocytopenia associated multi-organ failure. The sequential multi-organ failure is generally associated with lymphoproliferative disorder, where EBV is one thing what drives this multi-organ failure. But the immunoparalytic multi-organ failure is the most dominant one, to the point that majority of the patients who manifest with multi-organ dysfunction do have this immunoparalysis. Thrombocytopenia associated multi-organ failure is the second closest, and oftentimes they could be also coexisting. Now, why does this happen? Now, why does this happen is purely, it primarily depends upon the genetics as well as environmental factors. Patients who develop immunoparalytic phenotype, how do we recognize them? The absolute lymphocyte count, if it lasts less than 1,000 for 3 consecutive days, absolute neutrophil count, if it lasts less than 500 for 3 consecutive days, very likely they tend to have immunoparalysis, which means you need to give prophylactic antifungal and antibiotics in them, because they're very likely to develop secondary infection. Now, you could do more sophisticated tests by looking at HLA-DR expression on monocytes if it is less than 30%, or you could use ex vivo TNF response to lipopolysaccharide. If it is less than 200 picograms per ml, then you have immunoparalysis. Now, patients who develop TAMOF, that is thrombocytopenia associated multi-organ failure, they tend to have an abnormality in ADAMTS13. So their activity is less than 57% or inhibitory complement pathway. So patients who have soluble Fas ligand, they tend to develop sequential multi-organ failure. So all these three phenotypes, finally, if it's untreated, it can lead to hepatobiliary dysfunction and DIC. And that's how the macrophage activation actually manifests in children and even in adults. Now, it's important to understand a little bit about the cytokines, the important cytokines which are at play. Now, interleukin-1 beta, what it does is that it stimulates the hypothalamus, and that is the reason why they get fever. And it stimulates the neutrophils to provide even more interleukin-1 beta. And interleukin-1 beta can stimulate endothelium to increase interleukin-6, and interleukin-6 stimulates liver to produce CRP. And the interleukin-1 beta and interleukin-6 can have an effect on the bone marrow to reduce platelet count. Now, when this is a nice study which looked into the pathogenic pathway about what happens in bacterial sepsis, what happens in viral sepsis. So what we can understand in a very simplistic way is these are driven through inflammasomes, and I'll come through a few more slides to make it much more clearer, that in a bacterial sepsis, it is dominated by interleukin-1 beta. Like where I showed in the previous image, it increases interleukin-6, which increases CRP. And that's the reason we've been saying that you don't have to really measure interleukin-6, provided if you have a normal functioning liver, it almost always, the CRP is a surrogate marker for interleukin-6. And what happens in a viral infection is it goes through interleukin-18 pathway, and that increases ferritin level. So in many ways, the biomarker for viral infection is ferritin. You can use it like CRP for viral sepsis, and the CRP would not go up much in presence of viral infection. Whereas in bacterial infection, you might not have much of ferritin values, but it is more of CRP. And when they looked at various conditions and their CRP response and ferritin response, what they found out is that the bacterial meningitis, sepsis in adults, they tend to have much higher CRP response compared to a ferritin response. Pediatric sepsis, though, had a bit more ferritin response, higher ferritin response compared to adults. Whereas if you look at all the viral infections which are present on the x-axis, whereas HCV or EBV, HIV or dengue, all of them had a significant ferritin response and a very less CRP response. So that again corroborates with whatever the inflammatory pathway I just mentioned. One of the most difficult part to treat in pediatric sepsis is hyperferritemic sepsis. That's the worst kind of cytokine storm we would encounter. So what are the reasons? Why do they develop? Because we just spoke that the ferritin here or the macrophage activity does not happen through interferon gamma. So what happens most part is through red blood cells. So either a blood transfusion or hemolysis. So a lot of these patients who have sepsis, because of their endotheliopathy, they tend to have hemolysis. They might be occult hemolysis, might not be obvious hemolysis, or even blood transfusion. All that which releases free hemoglobin tends to act through CD163 receptor, and then that tends to increase the intracellular ferritin levels. And that increases extracellular ferritin levels. And this has been studied even by looking at the carbon monoxide levels, that it actually goes up along with ferritin. So this is the pathway by how the ferritin level actually goes up in critically unwell patients. So the hemolysis is a very important factor. Free hemoglobin is a very important driver for rise in ferritin level in critically ill patients. And this is important to understand because there are multiple ways which ferritin can go up. And in critically ill patients, there are different drivers. So it's not just purely through inflammatory pathway, but this free hemoglobin is also one thing which can significantly drive the ferritin up. So from transcriptional and translational point of view, the TNF alpha and interleukin alpha through the NK beta receptors can increase the expression of ferritin, and also the free iron in the form of hemolysis through the IRP1 receptor can increase the translation of ferritin. So both of this, the viral part, the inflammation, as well as the free hemoglobin, both of them can actually drive the ferritin up. Now, this is again an important image for us to understand because it creates a positive loop of increasing ferritin consistently. Now, what happens is, there are two routes, like I mentioned. One is a viral particles or DAMPs. All of them can stimulate TLR9 receptors, and that through inflammasome activation, through increasing interleukin 18, can increase ferritin production. The free hemoglobin, like I showed in the previous image, can also increase ferritin level. So two pathways to actually increase ferritin. Now, unfortunately, when the ferritin level goes up, what it does is it affects the stellate cells in the liver, creates an inflammatory state, and then causes liver damage and causes hepatobiliary dysfunction in the long run. So, and in addition to that, unfortunately, it has immunosuppressive effect, and it decreases the lymphocyte count, and it causes decreases lymphocyte activity. So the decreases T cell proliferation, causes energy, and even decreasing immunoglobulin production. So that again causes immunoparalytic state, like what we mentioned. So increasing ferritin worsens immunoparalytic state and then drives up the inflammation. So this is a similar image what I just mentioned, but it tells us the importance of therapeutics. How can we actually manage this condition? So now if you actually see, now patients like dengue, for example, they have very high ferritin levels. Now majority of that is because of their endothelial dysfunction, causes significant hemolysis, bleeding, and we give lots of blood transfusion. And this free hemoglobin part can drive the ferritin up very, very high, apart from the virus particle itself. We saw that viral particle through TLR9 receptors can stimulate increased ferritin levels. We also saw that through alternate mechanism, the RBCs can increase the ferritin production. So technically, for us to decrease free hemoglobin, PLEX becomes a treatment. You do a plasma exchange and decrease the level of free hemoglobin. IVIG, by binding to the viral particles, can decrease the TLR9 stimulation. So that becomes a therapeutic option for us. And then the interleukin-1, any inflammasome-driven process, interleukin-1 receptor blockade like anakinra is a very, very helpful to decrease the ferritin levels. So these are true therapeutic options we can use in patients who have very high ferritin levels. Plasmapheresis, IVIG, as well as use of anakinra. Now, I just mentioned also in my first slide that in the late phase, when the immunoparalysis stays for too long, there is viral activation, even in bacterial sepsis. So this is a study which looked into the ferritin levels, and they found out looked into different viruses. What you can find, what you can see in this study is that when the ferritin level keeps going up, the number of viral activations, so more than 3 viruses become active once the ferritin level goes more than 3000, which means even in bacterial sepsis, it's important we look for adenovirus in the blood. We look for all those HSV viruses, EB viruses, and these viruses can actually drive up the ferritin up. So if a patient's ferritin is going up in bacterial sepsis, it's really important we look for viral driven ferritin. Now, what is subsequently understood is there are patients like, for example, we know patients with some, for example, let's take an example of dengue, that the ferritin level just shoots up, goes up to a lag, they go into refractory shock, they develop hepatobiliary dysfunction, cholestasis, and we just lose them. Why does that happen? So this is a very nice basic science study, which was done in mice. And what they did was they gave both viral antigen and bacterial antigen, and then looked into what happens to the inflammatory state of the mice. So they gave either bacteria and bacteria, virus and a bacteria, or bacteria and virus. What they found in this study, as shown in this image, is that when you have a viral stimulus and followed that by a bacterial stimulus, that bacterial stimulus need not be alive bacteria, it could be dead bacteria, it could be just endotoxin. When that happens, it seems to drive the ferritin very high. As you can see in this image, you can see triglycerides going up high, ALT going up very high, and WBC counts crashing. So, and the patient develops a severe hyperferritic form of ferritic sepsis. So this is a mice study. Do we have any evidence for this in a clinical scenario? We do have certain evidences. This is again a study which looks into what happens to the gut translocation in the phase of in the dengue. So what we see is anybody who's having bacterial translocation, they tend to a very hyperinflammatory state. So it's in severe dengue, purely because of vascular leakage, it's very easy to have gut translocation, endotoxins from the gut. So you have viral stimulus and then followed by bacterial stimulus that can drive up your inflammatory state and can cause severe hyperferritemic sepsis. And also when we looked at our own data in our unit, we found that a lot of these patients who have very high ferritin levels almost always have a bacterial co-infection. So then there are some studies which looked into the concurrent bacteremia in critically ill patients with severe dengue. And what we can see is the mortality rate becomes significantly high when you have concurrent bacteremia. So, they have noticed it by high CRP levels and APTT, but we all know that the CRP levels do not go up as high in compared to other patients because of the hepatic dysfunction. So you can do a procalcitonin level that also is a reasonable marker to see in patients like dengue. So now that's about how the hyperferritemic sepsis could be harmful and bacterial sepsis can be harmful. How do we actually identify this inflammatory state, quantify this inflammatory state, and take therapeutic decisions? This is again a study done by Dr. Carcelo's group. They looked at just two commonly used parameters, that is the CRP as well as ferritin, and they saw at what value can you predict poor outcome. So they made 4 boxes and 2 intermediate boxes and 1 low risk box and 1 high risk box. And what they found out is if the CRP is more than 70 milligram per deciliter, this is 7 milligram per deciliter or 70 milligram per liter, and a ferritin level more than 373. When you have a combination of these two, both CRP being high and ferritin being high, the mortality significantly goes up. What we can see is the mortality going up till 21%. So this is what they saw in a hospitalized children. And when they saw that only CRP going up or one ferritin going up increases your risk, but it's an intermediate risk. It's not as much as both going up. So they subsequently did, when they did a backplot analysis, what you can see, the small blue boxes in the right upper end corner is a state where both ferritin as well as the CRP goes high. And this is the combination of what they saw in all those patients who had mortality. They subsequently did this same study in severe sepsis. And they found out that, okay, in severe sepsis, what happens? What happens to these two markers? And again, they found a very similar pattern, though the values were a bit different. The CRP here was around 40 milligram per liter, and the ferritin was much more higher, closer to 2000 nanogram per ml. So they found a similar thing. They found that when you had a ferritin close to 2000 and along with the CRP more than 40, your mortality went up to 40%. Whereas the CRP ferritin being less than 2000 and just CRP being elevated, the mortality was as low as 4%. So they found that more than a PRISM score, the combination of CRP and ferritin, the predicted mortality much more better than the PRISM score. And what they also found out was you might start off on your day 1 having a CRP high, having a ferritin high, but subsequently during the course, if both of them do come down, your mortality again goes to a lower mortality risk. It goes from 40% risk to 4% risk. And they actually showed with a few case examples they had in the publication. So for example, in this study, if you see, you start off with a high CRP, but with almost a normal ferritin level. And then they have done assessment of immunoparalysis using ex vivo TNF alpha. And what you can see that you have a reasonably preserved immune system. And with that, they see that the CRP comes down by day 5, day 6. The ferritin does not go up, and this patient actually survives. Whereas in this example, you start off with both high CRP as well as high ferritin, and immunoparalysis, your TNF alpha level is actually quite low. But during the course of illness, what you see is both levels come down. Your immunoparalysis child comes out of immunoparalysis, the TNF alpha response becomes much more better, and the patient survives. Now, in the last example, what you can see is, if you see in the x-axis, you have this TNF alpha level. It's almost zero. There's hardly any TNF alpha activity. And what you see here is the sequentially, the ferritin and CRP just going up, and these patients don't do well, and this patient finally succumbed. So when they analyze it in a different way, what you can see in this group, 4 groups, is a different combination of ferritin and CRP. And what you can see here is a group 5, the mortality reaches up to 40%. So when you see in group 1, you have a normal CRP, normal ferritin, mortality is 0%. Group 2, you see some elevation in the ferritin, but ferritin is normal, 5% mortality. You see a elevation of ferritin, but normal CRP, mortality is 6%. You see significant elevation in CRP, but not much of ferritin level, mortality is 11%. But when both go up, what we can see is mortality is touching around 40%. That suggests that the combination of CRP and ferritin can actually clinically predict the worst cytokine storm in septic patients. Now, this study was more interesting because they also measured cytokine levels. And so what happens to cytokine levels in this? What you can see here, a white color means a median level, blue color means a low level, a red color means a very high level. What you can see here is that TNF alpha level is blue in the patient group 5, which is almost approaching 0, which means they're in immunoparalytic state. And what you see is the red markers, all the inflammatory markers, the ferritin levels, MIP levels, the MCP levels, CCL2 level, everything goes up significantly high. So without measuring cytokines, just by measuring CRP and ferritin, we can safely make an assessment about the inflammatory state in sepsis. They did one more interesting study that with the same patient population, they subjected all of them to whole genome sequencing. And they found out all possible mutations, missense mutations based on the guidelines. And they found out how many of them actually had mutations. They found almost 50% of these patients actually had one or the other kind of mutations. Many of them probably were non-specific and of uncertain significance. So it seemed like quite a lot big of number, but many of them were of uncertain significance. But when you see this mutation analysis, and they looked at ferritin level and CRP level, platelet count and lymphocyte count, what they found that the odds ratio for high ferritin, high CRP, low platelet and low lymphocyte count was significantly more in those who had mutations. Now, why this becomes very interesting is because it also helps us probably in the future to see whether we can do precision-based immunomodulatory therapy in these patients, because each of this immunomodulation identified various antibody variants which can be targeted using IVIG, a dysregulation variant which we can use steroids and cytolytics, a phagocyte or innate variants where we can use GM-CSF or interferon gamma, anti-inflammatory variants where we can use anakinra or steroids, complementary variants where we can use steroids, plasma exchange, or eculizumab. So this can actually probably guide our therapy in future. So coming to the therapy, and I think one of the important therapy agent is use of interleukin-1 agent is anakinra. And this was initially reported in children more than a decade ago, where they said that the presence of HLH can be treated with anakinra. Then there was a huge adult trial which they did on septic patients. They did not find any improvement in outcome. So what they subsequently did was, when they analyzed that data again, and they used hepatobiliary dysfunction with DSC as a prototype, because that is the most common way with which HLH presents in sepsis. When they used that as their phenotype, they found there's a significant improvement, more than 33% outcome improvement with anakinra. And this study is quite significant and interesting, because what it told us is that the anakinra did not worsen the outcome in those who did not have this phenotype, which means it's quite a safe drug to use. So one of the concerns everyone talks when we talk about immunomodulation, we see it as an immunosuppressive drug. We see it as a toxic drug which might potentially decrease the outcome of patients. It's very important to understand that we're not, when we talk about Immunomodulation, we're talking about immunomodulation. We're not talking it's immunosuppressive medication. The idea is to reach immune homeostasis, not to suppress the patient completely. And that difference of understanding is very important for us. And this anakinra does exactly that. So it does not really immunosuppress other patients and worsen other outcomes. That's the concern we have with steroids, but with anakinra, we don't have that concern. And this study, what it showed was the mortality of those patients who had hepatobiliary dysfunction by improving the outcome by 30%. So when they divided in those with hepatobiliary dysfunction and without hepatobiliary dysfunction, the mortality was very low in those who did not have hepatobiliary dysfunction. Mortality was high in those who had hepatobiliary dysfunction and DAC. When you use anakinra, the mortality approaches the other group which did not have hepatobiliary dysfunction and DAC. So it equalizes the mortality between the two groups. So that's why it becomes a very fascinating drug in the management of HLH we see in sepsis. Now, we spoke briefly in that image about how do we treat hyperferritemic sepsis, because that becomes a dominant form of cytokine storm we see in conditions like dengue. So we saw that you can actually block the virus particles blocking by giving IVIG to prevent TLR9 stimulation. Free hemoglobin can be reduced by limiting blood transfusion, avoiding hemolysis, by probably doing plex if you have to give a blood transfusion, and being very mindful of the immunoparalytic state, because hyperferritic state is a septic state. So that's the reason we don't use steroids in this condition in our unit. And because of the coexistence, bacterial sepsis, like what I said, is much more significantly high. And what we also saw in our group of patients is many of them are multi-drug resistant because of gut translocation. So even empirically, if you have to put an antibiotic, many times you've got a blood culture positive, which is just sensitive to colistin. So it makes it really hard to choose an appropriate antibiotic. So anakinra becomes a very safe alternative in this group of patients. So these are the three combinations you could use based on the degree of hyperferritinemia, organ dysfunction in this group of patients. So again, this image kind of summarizes what I just said. So in presence of overwhelming early phase of illness, we focus on giving antibiotics. We give as a primary therapy, and in toxic shock syndrome, we might give IVIG as a therapy. But we know beyond day 3, it's almost always cytokine-driven organ dysfunction. So in addition to supportive therapy, we always think of other immunomodulating drugs when to consider plasma exchange, IVIG, steroids, and anakinra. And be very mindful that almost all patients with MODS in sepsis, they are immunoparalytic. Secondary viral activation is common, and that can drive hyperferritemic sepsis. So with that, I'll conclude my talk with key points that immunodissonance in sepsis leads to cytokine storm. CRP, ferritin, platelet count, absolute lymphocyte count are very useful markers in managing cytokine storm. Genetic and environmental factors lead to different clinical phenotypes in sepsis. DAMs, PAMs, and decreased cytokine P250 might lead to cytokine storm. Poor NK cell activity and lymphopenia leads to immunoparalysis, and that's common in multi-organ dysfunction. Persistent macrophage activity independent of interferon gamma leads to HLH in sepsis. Hepatobiliary dysfunction with DAC is a common is the way HLH manifests in sepsis. And we also saw that viral infection followed by bacterial infection causes severe hyperferritinemic sepsis, a severe form of cytokine storm. DNA viral reactivation might lead to ferritin rise in bacterial sepsis with immunoparalysis. Free hemoglobin and DNA viruses can create a positive loop for ferritin production. Anakinra is a very safe drug and very useful drug in the presence of hepatobiliary dysfunction and DIC. You can consider use of plex in presence of hyperferritemic sepsis and in thrombocytopenic microangiopathy. So our armamentarium to treat these patients is IVIG, steroids, anakinra, GM-CSF, and plex. Immunophenotype offers a very exciting therapy to offer a immunomodulation with a great precision. With that, I conclude my talk, and I thank all my fellows for helping me in making this presentation. Thank you very much.
Thank you, Rakshay, for that really illuminating talk. The more we hear about this, the more we understand how complex this pathophysiology is. And your talk actually helps simplify a lot of that, even though not everything, obviously. I have a couple of questions before we open the session for other questions. One was your first patient which you presented. Maybe I'm wrong, but did I see that on day 3 you had given them steroids? Is that correct?
So I think the patient came to us on day 7 of illness, and we gave steroids on the day 1 of admission itself.
Because it takes a lot of guts to give pulse
Yeah.
steroids to a child who comes
Yeah.
to you with septic shock. So how do you decide when to give steroids to them?
Yeah, so I think, like I just mentioned, steroid is not our first go drug, but at that point in time, we were in the middle of COVID pandemic, and then MISC was something we are seeing quite often. So I think with MISC, we became much more confident in certain phenotypes to use methylprednisolone much more confidently. But like you just said, I think one of the difficult decisions in choosing drug is our assessment about how we assess in what way we think infection is the most common reason, most likely reason. So in this particular patient, we just felt probably it's one of the more of a messy kind of a manifestation what we had. And that was the reason, if I remember, we gave methylprednisolone, right. But otherwise, we generally choose anakinra in those patients whenever we have doubt, or we go for IVIG whenever we are unsure about the infection being a predominant manifestation.
Okay. The next question is about anakinra, because we're all hearing more and more uses of anakinra, it's great, and it's actually not that expensive. With you and Chandrika here, now the problem is it's not officially available in India. So what can we do to make it available? I mean, yes, so we can get it, but it's very difficult, as you know.
I think I'll allow Chandrika to answer, because I'm told by her that it's going to be available soon in India. Is that correct, Chandrika?
No, I don't know about that, but I think there are some companies which are planning to make biosimilars. That's in the pipeline. So once that happens, maybe we will have more easy access to anakinra.
Chandrika, Rakshay, can I make a comment, Rakshay?
Yes, please.
So, Bala sir, regarding this anakinra, it is produced only by one company called Shobi. That's the only company produces that, and it is mainly approved for our autoinflammatory syndromes abroad. So India, that they don't have a DCGA approval to get this drug, and to get they want to do a trial in India to get it approved. This is what Dr. Ramanan told some time back. That's the reason it's not available. But you can actually import for patient name. That's what Chandrika has done. Okay, you can get it as a 24 vials, and you can keep it anywhere. I want to do it in CMC Vellore to keep the drug in our pharmacy, but because it's an institution, our head said that because it's not a DCGA approved drug for any indications, we couldn't bring it to our hospital. Any private institution, anybody wants to, it's not costly, it's about 10,000 rupees. So you can bring it to India. It's not like not available. Is that correct, Chandrika?
Yeah.
Yes, that's right. So 100 milligram vial would come up to 10,000 rupees for the patient, which is lesser than the cost of meropenem even that we use in our patients. So cost is not a factor. It's just the processes that are involved in importing the drug that's an issue as of now.
Yeah, but then it's you have to import it in a pack of 24. That's 240,000.
Yes, 28 vials, and the cost would vary depending upon the running dollar price. So if your hospital is ready to invest in the entire pack, it's definitely worth an investment to make. And it has a shelf life of 2 years. So it's not that if you get it, you're compelled to use it in a month or two. And I'm sure with the number of patients that will benefit from this, you would use the stock pretty soon.
So now I will tell unofficially, Sir Chandrika is the sole proprietor of anakinra. Today also send a patient there to get it. Anybody can get and keep it.
No, can I interrupt? I have proprietorial things too. We stock anakinra in our hospital, and I've only used it last week for a patient. So it is very much possible for you to stock it and keep it, and to use it as and when it is a very, very useful drug.
Okay, so now we know who to contact. Okay.
I think
there are
questions in the chat box, if you could take those.
Yeah, there are some questions in the chat box. You want to go through them, Rakshay?
Yeah,
or,
sure.
Yeah. Okay. So there is.
So I think
Suma,
there is a question about insignificant mutations in the context of HLH phenotype. Is it really significant? And I think over time, with more and more whole genome sequencing being done, we will probably understand the significance. But certainly that study which I mentioned, it gives a signal that many of these patients do have a genetic predisposition. So then there's a question about patient with immune dysregulation will always go through immune paralysis and then mass. So what happens in a lot of this multi-organ dysfunction related to sepsis, they do have immunoparalysis. And like I just said, because their inability to clear infection drives the inflammation through the mechanisms and pathways which I mentioned, and that leads to a lot of macrophage activation. And that macrophage activation does not happen through interferon gamma pathway, but through those pathways which I just mentioned, and that can lead to macrophage activation syndrome and subsequently hepatobiliary dysfunction. Is there any difference between timeline of a patient with cytokine storm and patient without cytokine storm, clinically and biochemically? So technically, if a patient has a good immune response, he should recover clinically without organ dysfunction. So cytokine storm, generally we say when there's organ dysfunction. So obviously when you have an organ dysfunction, your course is going to be much more longer than otherwise. What's the duration of steroid you're using in your unit in sepsis related HLH? Like I just mentioned, it is not something in generally in a bacterial sepsis, we have avoided using steroid. We don't use it as much now with the available of anakinra. The steroids we have used more in the context of cytokine storm related to MIS-C, but otherwise we generally go with use of anakinra.
Dr. Soma has asked a question on the webinar chat. Is there really a dengue hepatitis or is it all HLH?
Yeah, so I think the early part of liver dysfunction, if you see the STOT and STPT, the STOT levels are much more higher than PT. It seems like more of liver inflammation, and then you also see in subsequently in hyperferritemic sepsis, what you finally see is more of a hepatobiliary dysfunction with cholestasis, and that's how the HLH manifests. There are probably segment of patients who land up with hepatic necrosis and then we can't do much about them. So there's probably a combination of both. So you probably see both. And that's probably one of the reasons why it becomes very difficult to quantify outcomes, because when you say there is a liver dysfunction, we don't know what actually the pathogenic mechanism is. Is it because of direct liver injury and hepatic necrosis, or is it because of liver inflammation? And I think what we have noticed is presence of cholestasis over time. Bilirubin levels more than the OTPT, if that keeps going very high, that's not a great marker, and that almost kind of is quite late in the illness.
Yeah. Dr. Guru Prasad has asked a question. Sepsis more than 7 hours, multi-organ dysfunction, hepatobiliary dysfunction, and ferritin elevated. Is this a reasonable scenario to consider? I think you just answered that. Yeah.
Yeah.
You know, anakinra would be better. And you had actually mentioned in your talk that for these kind of patients, you would give them IVIG, you would do plasma exchange, and then give anakinra.
Yeah. So I think this is in viral sepsis related HLH, in the severe form, where you see hyperferritinemic sepsis, we would consider all this. But in bacterial sepsis, we might not. But certainly in hyperferritemic sepsis, where the ferritin level really shoots up. And I think you asked the question earlier too about the ferritin level being more than 10,000. So I think that being more than 10,000, where people have just taken only ferritin as a sole value in presence of fever, and presence of fever and ferritin being more than 10,000 as a combination says that HLH is very high. That doesn't mean that 2,000 is not HLH. It is just that they look at only ferritin levels, and ferritin level being more than 10,000 in presence of fever, it is almost always it's HLH. Whereas you could still have ferritin of 2,000, 3,000 and still have HLH, provided it fulfills other criteria.
There is another question. Is the cytokine profile IL-1 and IL-6 level, should it guide our decision regarding using anakinra or tocilizumab?
Yeah,
or is it?
Yeah, so I think I just, like I mentioned in the study, using CRP, using ferritin, using your platelet count and lymphocyte count, it can give us a lot of information. So I said the combination of ferritin, is it a predominantly ferritin-driven process, or it's just ferritin plus CRP? Looking at platelet count and looking at, and that can give us an idea about microangiopathy. Looking at lymphocyte count, it can give us an idea about immunoparalysis. And I think a lot of our therapy can be guided through that. And like we just saw, as long as the liver is fine, the CRP is a good surrogate marker for IL-6 levels. So I don't think I mean, many of us don't have an access to it, and probably we can utilize these simple clinical tools, which we do daily, quite regularly to guide therapy. And like that, Randy Flanes mentioned in the table that interleukin level is very, very hard to measure in blood. Yeah.
Yeah, and CRP is much cheaper to measure than IL-6 anyway. So, oh, there are more questions below that.
Should we take them up in the chat box or?
Yeah.
No, in the Q&A, there are more questions in the Q&A. Should we as an Amish Vora from Bombay has asked, should we as an intensive care society call this secondary CRS as macrophage activation instead of calling it HLH? Because medico-legally, you couldn't fulfill HLH criteria where MAS is easily possible, or come up with our own guideline.
Yeah, so I think it's that's the whole problem. I think throughout the conference we've said certain labels can create a problem. So it's not very clear if all of us are talking about the same condition when we use multiple terms. And like we just mentioned, the protocols mentioned for primary HLH is not a suitable protocol for patients we see in sepsis. So I think that we should be very mindful.
Yeah, in our unit, we never, the three people in our unit, and none of us agree on what to do with these children. Each one has his or her own biases. So depending on who's on duty, the treatment will vary. So I generally don't label them as anything. I just call them hyperferritinemic state. And then, we go from there. There's another question. Does the high level of ferritin and inflammatory markers define how the cytokine storm and need for urgent intervention? I would say yes.
I think the degree of rise of CRP and ferritin, like we just saw in that studies which Dr. Kasula's group has done, that if both are very high, obviously it means you're in a much more higher inflammatory state.
Can we questions in the Q&A box, because I think we're running out of time to just...
Okay. All right. Okay.
I'll do that. Sure. Thank you.
Thank you, Rakshay. Thank you so much.
Thank you.
So after that absolutely fascinating talk, it's my utmost pleasure to introduce the next speaker, who's also one of the organizers of this meeting, Chandrika Bhatt. So Chandrika is one of the promising members of the Pediatric Rheumatology Fraternity and Faculty of India. She's trained in Pediatric Rheumatology in Bristol Children's Hospital, where she also worked as a consultant pediatric rheumatologist, and then has returned to offer her services in the same field in Rainbow Children's Bangalore. And her areas of interest are immunomodulation in critical care and tropical infections, CRMO, and pediatric uveitis. Over to you, Chandrika. She's going to talk to us on identifying the cytokine storm and tools in resource-limited settings.
Yeah, so thank you, ma'am, for that introduction. I think after that heavy talk, I'm going to keep it very simple and just touch upon the tools that in our background we can use, and we don't always have to rely on fancy tests to think or diagnose a child as having cytokine storm. So this is the main objective of my talk. All of us are very comfortable with diagnosing and suspecting overt cytokine storm, but that is just the tip of the iceberg. And what we really miss out on is early cytokine storm, wherein these children probably are more amenable to being treated with less number of drugs, and they have better outcomes. So this is what I'm going to go through with the next set of slides that I have. So depending upon which specialty you're practicing in, you may look at the elephant differently. But what is important to know is that we probably are looking at the same condition from different spectrums where we are comfortable in. So being in the ICU, you may label it as hyperferritinemic MODS, hyperferritinemic sepsis. Being a rheumatologist, I would call it macrophage activation syndrome, and my hematology colleagues would call it hemophagocytic lymphohistiocytosis. But it is important that we don't get stuck on these labels. We need to interact with each other and realize that all of us have to pitch in managing these patients, because what we really need to know that this is a continuum and not a single diagnosis that we are looking at. And in the intensive care world, like a lot of people have already alluded to, you call when a child is sick, you say the child is in shock, but there are really different kinds of shock that the child may have. And similarly in cytokine storm, the etiology may vary in every given child, but what is important to recognize that final common pathway might be the same in most of them. So what are the issues we have surrounding recognition? There is a myth that this is probably not a very common condition, that this is still very exotic, and maybe just COVID has brought about more interest in this condition. But actually, a lot of infections in our setting can lead to cytokine storm. And as Dr. Rakshay mentioned in his talk, not every child with an infection lands up in the ICU. So there is something else going on when you label a child as having septic shock. I'm not an infectious disease specialist, but If you're saying cultures are repeatedly negative and the child is not getting better, and if this bug is so destructive that the child has landed up in ICU, then probably you need to consider some host factors as well, rather than just the infection as the cause of deterioration. And being too dogmatic about criteria. Now, the criteria that were devised were mainly devised for research purposes. They were not actually made for diagnosing a child as having HLH or not. And more so, these research criteria were made for primary HLH rather than secondary HLH. And now we know that secondary HLH probably forms a greater bulk of the patients of cytokine storm that we see. And this really leads to an urge to have a definite label when we see these children. People want to call it as having HLH or not having HLH. But what you need to know is this is a spectrum from mild to severe, and you might be seeing the child when they have mild cytokine storm. And this is the point, really, if you intervene, you can change the outcome of this child. And again, we still have not gotten better with time with our research in finding a single diagnostic test that will tell us, yes, this child has cytokine storm and whether we can safely go ahead with treatment or not. And in our Indian setting, we probably still don't have access to the right testing center. But by that, what I really want to enforce with my talk is you don't really need fancy tests all the time. And that's what I'll go through in the next few slides. And financial constraints. So again, having financial constraints means you probably need to think of cytokine storm way earlier so that you don't need to subject your patient to a lot of medications, which might be expensive over a period of time. So what can we do to detect earlier? I don't need to tell our astute audience that we always need to revisit the history, go through timelines, which are very important to know the day of illness, especially when you're looking at infections. And when they reach a point wherein you expect them to deteriorate, for example, with dengue, which most of us are comfortable managing, by day 4, day 5, you probably should start thinking of cytokine storm if your child is becoming unwell. Family history, more in the context of primary HLH, when there is consanguinity in some backgrounds, that's an important point to consider. And examine your child daily. New onset hepatomegaly, new onset splenomegaly. These basic tools are very important in picking up HLH. And the course trajectory. I think this is by far the most important tool that we have. On a day-to-day basis, you have to match the results that you get, the examination findings that you see, and see if it's in line with the patient's clinical status. If some labs are getting better, but your patient is deteriorating, probably you need to go into the depths of evaluation further. And always be alert to know whether your child is responding optimally to your treatment or not. You may get a blood culture saying your child has E. coli or Klebsiella sepsis, but if they are not responding to these appropriate antibiotics that you started them on, then the question really is if there is something else going on. And what do we have to evaluate? We have multiple criteria that have been laid down in the past, and there are a host of lab tests that we can use to diagnose HLH. So this is the criteria most of us are familiar with. And like I said, this was predominantly made to diagnose primary HLH. And if a child fulfills 5 out of the 8 criteria that's mentioned below, you label them as having HLH. And this is what most of us are comfortable doing. But what we need to know is there are some fallacies with the criteria. First of all, it is a classification tool, not a diagnostic tool, and it really doesn't pick up the spectrum of disease. So you may have a child having mild to moderate cytokine storm who may not meet the criteria for HLH laid down over here. And if you are too dogmatic about them fitting in this criteria, again, like I said, the child will deteriorate by the time you diagnose them. And it is important to know in our context that a lot of times children can have atypical presentations of common diseases. Being aware of this is extremely important, in that not to always think of an exotic diagnosis, but a common complication of a simple diagnosis. And as we know, some of the tests mentioned over here, like NK cell activity, soluble IL-2 levels, we don't have easy access to them, and even the turnaround time might be quite a lot in our setup. So this tool was then laid down, the EDGE score, which is probably more relevant to secondary HLH. I have put up the table here of all the points that are included here. And if you score more than 168 on the EDGE score, so you have 100% sensitivity of diagnosing a child as having secondary HLH. And you don't really have to by heart this table. There is this online calculator wherein you can put in the scoring system every day and it will generate a score automatically. So this is quite useful in probably bringing up a red alert as to when a child is going towards cytokine storm. And this beautiful exhaustive algorithm was written by Scott Kanner's group. And what they said is if you're suspecting a child as having HLH, you do tests mainly to look at immune activation, to look at immune pathology, underlying trigger, and then assess the severity of organ involvement. And based on this, you can probably then subdivide your evaluation into knowing who has more evidence of HLH, what is the underlying trigger for HLH, and some genetics if you have access to them. And this essentially, that was a very exhaustive list, but this table actually simplifies it in saying what are the tests we do and what we are actually looking for. So in a child who has an underlying immunodeficiency, which Dr. Surjit Singh very beautifully alluded to, a low or absent NK cell function, genetic defect of cytotoxicity, and even family history of HLH probably adds to the diagnosis. Whereas when you're looking at a child with prolonged fever, new onset hepatosplenomegaly, elevated ferritin, soluble CD25 or IL-2 levels, and soluble CD163, you're looking for signs of immune activation. And then in end organs, you can look for abnormal immunopathology. So in the blood, you will look for new onset of cytopenia, especially bicytopenia is more sensitive for HLH, decreased fibrinogen levels. Now, again, all of us may not have access to fibrinogen, and most of us may not do it thinking it's an expensive test, but a very simple surrogate marker for fibrinogen is ESR. So today, if you have a child with the ESR of say 60 to 70 with a CRP of 50, tomorrow when you see the child, he's continuing to have fever, CRP has gone up to 150, but your ESR has dropped down to 10. You shouldn't be happy with that. That indicates that the fibrinogen levels have crashed and this child is progressing towards HLH. And hemophagocytosis in tissue, we know it's not a very sensitive marker. Many a times you may not have hemophagocytosis in children even with frank HLH, and the converse. You may get hemophagocytosis in tissue even when they don't have other features of HLH. But if you do find, it adds to the diagnosis, but it's not something very sensitive. And I'll come to the other two features mentioned, which is hepatitis and CNS involvement. And the most important thing is that these efforts have to be simultaneous. You have to look for underlying trigger continuously, signs of immune activation and immunopathology all at the same time and not one after the other. So I'll use a case scenario to just go through these tests that we use. So this is a 4-year-old girl who was referred to us with a history of fever for 1 month, which was low grade initially, and she had some history of on and off oral ulcers. She was otherwise well. She was a daughter of doctor grandparents. She had a CBC done once, which was normal. Now, because she only had low grade fever spikes, they decided to wait for a couple of weeks before they sought help. And when the fever spikes actually increased in intensity, and by then her oral ulcers had actually healed, she came to us, and on examination, apart from a soft hepatomegaly, there was nothing else that we could see. So we ran initial labs. As you can see, a full blood count, hemoglobin was fairly normal. Her total counts were on the lower side, and the absolute neutrophil count was actually low. Platelets and platelet counts were normal. CRP was borderline, our cutoff is 6. And on the liver function test, her SGOT was high, more than the SGPT, but her albumin levels were normal. LDH was elevated, ESR was 50. So whenever we look at SGOT, SGPT, and LDH being elevated, I usually do a CPK as well to see if muscle is the source, but that was normal. Her initial cultures were negative. And because she had prolonged fever, we got an echo mainly to look at any coronary involvement. And they said she had a thickened AV group. She underwent a cardiac MRI, which was absolutely normal. But her fever spikes continued. So these were the initial differentials that we had considering the long history of fever, whether we were looking at an atypical infection or a partially treated infection, malignancy, or immune dysregulation. But really at the back of our mind, we were also thinking if this girl has evolving macrophage activation syndrome. And for this, I will come to the reason why. So the conventional tools all of us are comfortable with is prolonged fever or recurrence of fever in a child if they develop new onset hepatosplenomegaly, new onset cytopenia. So in cytopenia, your thrombocytopenia is the most sensitive. That's the one usually that goes down with the onset of macrophage activation, followed by hemoglobin and the WBC count. Rise in CRP and ferritin levels going up, along with tissue diagnosis of hemophagocytosis, rise in triglyceride levels, and a drop in fibrinogen. We all know this is HLH. But so these are, to just summarize, the lab features that we look at. And again, I would like to reinforce that tissue hemophagocytosis is not necessary for diagnosis. But what are the caveats with these tests that we have? Now, CRP favors hyperinflammation, but we do know that a lack of rise in CRP does not always exclude the possibility of cytokine storm. And this is what was also mentioned by Dr. Akshay's, in Dr. Akshay's talk when he spoke about Dr. Joe Carcelo's paper. A lot of viral infections, you can land up in cytokine storm even without a rise in CRP. And viral infections like dengue, Ebola, even COVID in some cases have been quite significant for that. And when you have a child with significant liver function, and most of our children with dengue, we do see that they never mount a CRP response for that reason. So always relying on CRP is not a good idea. You have to look at other inflammatory markers in toto. Now, ferritin, we all know, is quite sensitive, but a cutoff of 500 is probably not very sensitive. And the specificity goes up actually at levels of around 2000 to 10,000. And tissue hemophagocytosis, I already spoke about it, but what it might for example, doing a bone marrow, this is what we are very commonly asked, whether we need to do a bone marrow before we diagnose a child as having HLH. So a bone marrow is not mainly for diagnosis, it's probably to rule out other conditions, and the main condition we are worried about is malignancy before we subject these children to immunomodulation. So you can see in the first image over here, this bone marrow has very beautifully picked up a macrophage engulfing a neutrophil, and this has probably added to the diagnosis of HLH. But in the second image, you can see this is a macrophage which has engulfed a neutrophil, but there's something else also that you see over here. This is a fungal spore. So here the bone marrow has actually not just helped in picking up if there is hemophagocytosis or not, but it's probably given you the answer to the underlying trigger for hemophagocytosis. And in the third picture, you can see again, there is a macrophage engulfing a neutrophil, but you see a lot of other abnormal cells, and this child actually has leukemia. So this is actually the value of bone marrow in not detecting hemophagocytosis, but probably giving you an answer regarding the underlying trigger. And when you have children with atypical or evolving disease, so yesterday in Dr. Akash Deep's talk, he spoke very well about liver inflammation in HLH. So when you have cytokine storm, what you need to know is that in the liver, first you have portal inflammation, then sinusoidal, and then lobular inflammation. This is important to know because initially you may have just an elevation of AST, ALT before you see an elevated bilirubin level. And this is actually the timeline of liver dysfunction. So first you'll have transaminitis, and even in this, the SGOT always is higher than the SGPT. With due course of time, your LDH and ferritin will also go up. When there is lobular inflammation, the bilirubin, usually the conjugated portion goes up because of cholestasis, and then this patient will progress towards coagulopathy. And this is probably the point when this child is going to meet all the criteria that have been laid down for HLH, but this child is also going to be more sick when you're going to detect them at this stage. So essentially what we are saying is that there is a green zone to detect hyperinflammation. So always put your radar up if a child has elevated SGOT, SGPT, normal bilirubin, normal PT-INR, please look at other inflammatory markers. And this was summarized very well in this paper by Michael Jordan's group, where they said that in their experience in HLH, there is always evidence of liver inflammation, and which may range from mild transaminitis to fulminant hepatic failure. And if they see a child without any degree of hepatitis, probably that excludes the diagnosis of HLH. Now, central nervous system dysfunction, this is another very commonly under-recognized coexisting factor with HLH. And this is more common in patients who have hypomorphic mutations. Again, I'm not saying you need to do genetics and all of them, but they can have a huge range of CNS feature ranging from seizures to meningismus to even psychomotor retardation and ataxia. So what you can do is a simple lumbar puncture. You'll see CSF pyocytosis, but actually a lot of them have very high protein levels, and at times this may be disproportionate to the rise in cell count. And now moving to the fancy tools, NK cell function. So Dr. Sujit Singh very beautifully spoke about its importance. But what I would like to re-emphasize is that NK cell function is good at picking up primary HLH. So if you have very low NK cell activity, probably that is more in line with a genetic cause for HLH, but it's not very specific because NK cell function can be suppressed even in overwhelming sepsis. So it's used mainly as a screening test for familial HLH, but I wouldn't rely on it completely for diagnosis. Whereas soluble IL-2 levels, it's a very useful inflammatory marker. It's probably more sensitive than ferritin levels. You can see the sensitivity going even up to 100%. And it can even, so if you do soluble IL-2 levels by ferritin, you can even differentiate the underlying trigger, especially in lymphoma, the ratio goes up very high. But unfortunately, most of us don't have access to this. By the time we get the reports, the patient would have already deteriorated. So coming back to our patient, we looked at all these factors. So for her to suggest immune activation, she had fever and hepatomegaly. To suggest the immunopathology that was going on, she had cytopenia, which is neutropenia, and some evidence of transaminitis in her case. So we looked at all the underlying triggers. We ran a huge exhaustive list of infection screen with the help of our ID team for viral, bacterial, atypical, and parasitic infections. None of them were conclusive. If that wasn't enough, we also started her on empirical antimicrobials as well to cover any possible infection she might have had. There was a history of travel to Bihar before she came to us, so we treated her for probable Kala-Azar as well, but this was not there on the bone marrow. So we then went ahead and did a bone marrow in her. There was no evidence of malignancy or Kala-Azar. We even did a PET scan to look for any nodes that we could biopsy, but that was also normal in her case. We then involved the gastroenterologist. So she did a fecal calprotectin, serum cellular plasmin to look at metabolic causes that could cause HLH, but all of them were negative. We then did a liver autoantibody profile, but they were not very happy with this report because they felt it was not consistent. Although positive, it was not consistent with her clinical features. So eventually we went ahead with a liver biopsy, and what it showed was some degree of inflammation around the portal tracts, indicating there was just evidence of hepatitis, which we can see in HLH as well. And to look at immune dysregulation, we did an immunoglobulin profile, ANA, ANCA, C3, C4, everything was non-conclusive. So this was her course. She continued to have fever spikes. Her ferritin initially was only 238, but when we repeated slowly, it had gone up to 1,500. But what is interesting is that her cytopenia had worsened. Her WBC count had dropped to 1,900. Her ESR, like I said earlier, was 50. It had dropped suddenly to 5. CRP continued to be normal, whereas her SGOT, SGPT kept going up. And by now, her total bilirubin, as you can see, has slowly gone up to 1.1, with a direct conjugated fraction being 0.6. So at this point, really, we thought since we have no alternate diagnosis and most of her features probably were in keeping with HLH, we decided to pulse her with steroids. And she did very well with her fever completely resolving. After that, she used to spike 102 to 104 degrees Fahrenheit. Everything crashed and she did very well. Although we didn't know the underlying cause, we decided to taper her steroids and see how she did. So we sent her home on steroids at 2 milligrams per kg. After 3 days of pulse therapy, she was fine for a day after she went home. But unfortunately, she came back again 24 hours later with high swinging temperatures when they moved to 2 milligrams per kg of steroids. And this, I briefly summarized her course after that. So when she came back, we had already done most of her tests for infection and malignancy. So we decided to pulse her again with steroids, this time at 30 milligrams per kg. We started her on anakinra and IVIG as well. And as you can see serially in her labs, her WBC count continued to drop with significant neutropenia. Her platelet counts continued to drop. Her OTPT kept worsening. But what I would like to bring to your attention is that her CRP never budged. It was continuously in the normal range, even though her ferritin levels peaked up to 25,000. So we really didn't know what was triggering her disease activity over here. So we hiked up on her dose of anakinra. We even put in cyclosporin, went up on the cyclosporin dose. Empiric antimicrobials, including antifungal coverage, was continued. And then we involved our hematology team, thinking we probably should give her 1 dose of etoposide. By then, we sent her genetics. We started speaking to parents about probably preparing her for a transplant if required, if nothing else works. And we also sent her NK cell activity for primary HLH. So we gave her 1 dose of etoposide at 50, half the dose, 50 milligrams per meter square, but she still did slightly better in that fever spike started coming down. And then we eventually gave her another dose at 75 milligrams per meter square. And this is the importance of giving attenuated doses of etoposide. You don't really have to follow the hardcore HLH 2004 protocol. And after we gave her the second dose of etoposide, she went into remission. Her fever spikes stopped abruptly. Her ferritin levels for the first time started trending down and the platelet count started improving. So by then we got the results of her NK cell activity, which we had sent to KEM Mumbai, and her NK cells unfortunately were low. So they said they couldn't do the NK cell activity. We also got the results of her genetics, and much to our surprise, she did not have any evidence of primary HLH as well. So there are some newer tests that we could have probably used to pick up HLH much earlier in this girl. CD163, which indicates macrophage activation, IL-18 levels, which indicate inflammasome activation, and CXCL9, which indicates interferon gamma pathway activity. But none of these are very easily available in the Indian scenario. They're probably more of research tools. And like I said, again, it might be too late by the time you get these results back. So in summary, having gone through the case that I just discussed, any drop in hemoglobin, platelet count, neutrophil count with a drop in ESR, that is a very good marker. You don't have to do fibrinogen in all of them. A drop in albumin, sodium would be indicative of HLH in a child who's continuing to have fever spikes, and a rising CRP, ferritin, triglyceride. And very important, what I've re-emphasized with this case is LDH and liver enzymes. Again, tissue hemophagocytosis is not mandatory, but it adds to the diagnosis. Genetics is an important tool, but I've not touched much upon it because Dr. Grant-Schullert already did it on day 1. But what really is very important in our context is to always look at the progression of disease in line with what the underlying diagnosis is, repeated review of history and examination, and trend the clinical features along with your blood work. So I conclude with these take-home messages saying it takes a village actually to diagnose and manage these children. So in the girl that I just mentioned, we had our ICU ICU team, our gastroenterologist, hematologist, ID consultant, and me, all of us looking at this child on a day-to-day basis. And what we need is more of a syndromic approach rather than a diagnosis-oriented approach. It may be a while before you actually pin down on the underlying trigger, but don't wait for that to start treatment. Keep an open mind, always search for underlying triggers every day if your child is not getting better. We don't have a single diagnostic test as yet to diagnose or disprove HLH, but what we need to know is time is essence over here. So waiting for too long may not be a great idea. And at times response to treatment may qualify as a diagnostic test if you have nothing else that's positive. And it's very important to reach out to experts. And for that, I would like to acknowledge Professor Ramanan and Yaninge Henter, who really helped us with this patient. And I conclude with that. Thank you.
That was utterly fascinating, Chandrika. Let's look to see what questions we have. So there is one new question which says, does the high level of ferritin or inflammatory markers define how severe the cytokine storm and the need for urgent intervention?
So again, I think it's not that we need to look at just one marker in isolation. It's you need to plot the labs that you get with the clinical profile of the patient. So I've learned this from our ICU team that sometimes you may see a child with dengue with ferritin of 10,000 or 11,000, but that doesn't mean you need to jump in and give them immunomodulation. You need to look at what day of illness it is. What are the other parameters? For example, if the child is otherwise improving, fluid requirement is coming down, heart rates are coming down. So in this child, all the ferritin levels are high. You don't necessarily need to treat the ferritin level. It's more about treating the clinical condition of the patient.
Absolutely. It's not, we're not treating lab tests, we are treating the patient underlying. Would anybody like to ask any questions before I ask one or two questions, Chandrika? Satish, anybody has a question for Chandrika?
Chandrika, this regarding this, suppose we have a child with suspected cytokine storm, and we have a ferritin is about some 2000. It's not very high, it's not very low. Does soluble CD25 help in those patients?
Absolutely. So soluble CD25 goes up very early as well. And it's a very sensitive marker for HLH. So probably if you have very high soluble CD25 or IL-2 levels, more than 2,400 is the cutoff that's mentioned. But again, it's not the cutoff that's important. If the patient is having progressive cytopenia and if your soluble CD25 levels are high, probably this child is going to progress over the next few days. And it's a good point not to wait for that and intervene before then.
Sure. Thank you.
I think one of the biggest take-homes from your talk, Chandrika, is the fact that, you know, what I've seen also is that many of these children get referred to neurology, gastroenterology before, you know, before there's a realization that the actual problem here is something else. So the awareness that when you're seeing a child, many people don't look at the dropping counts in this scenario. They don't tie up the whole situation that's happening to the child. And one of the biggest awareness that needs to come out from your talk is the fact that people need to consider that, you know, every child with a high-grade fever and liver dysfunction isn't necessarily a primary liver disease. You have to look at the rest of the clinical situation and think about HLH. You have to think more and more about HLH, because actually it is quite common on our intensive care units. It's not that rare. Whether we may not need to treat every child, but we certainly need to be able to pick out the problem and look at the child from that perspective. What do you say?
Yeah, absolutely. I think we need to, that's why I said, have a broader differential in mind when you're seeing a child. If not everything is determined by the organ that's involved alone. The organ that's affected might be a part of a systemic disease. And that's always important to keep in mind than just focusing investigations along one organ that's involved. And that's where I think having awareness of how these lab tests actually what they reflect is very important. So always putting down SGOT, SGPTS in, you know, I think sometimes saying hepatitis might be a misnomer because we then think that it's something just related to the liver, whereas that means that there is some inflammation going on and liver is perhaps just one of the organs that's affected. So knowing that is very important rather than just limiting our diagnosis to one organ that we think may be involved.
Yes. Thank you. That's great. I think it was very useful talk, and we can move on to the next.
So
Are
thank you.
there any questions?
I think there are no further questions.
Okay.
Yeah.
Thank you.
Thank you. So I think with this, we'll move on to session 2. I would like to thank our chairpersons for the wonderful session we had earlier. For the next session, I would like to invite our chairpersons, Dr. Jayashree Muralidharan. She's the Professor and Chief of Pediatric Emergency and Intensive Care Unit at Advanced Pediatric Center, PGI, Chandigarh. Her areas of interest include diabetic ketoacidosis, antimicrobial resistance, ARDS, capacity building initiatives, and critical care nursing. She has been the national convener for IAP ALS between 2014 to 2016. She is Asian representative of World Federation of Pediatric Intensive and Critical Care Societies. She's a scientific member of Pediatric Acute and Critical Care Medicine Asian Network, chairperson of the APC COVID Management Committee, and member of the national task force that formulated operational and management guidelines for pediatric COVID. She won the SCCM Innovation in Education Award 2021 for her impact module in Madhya Pradesh, and Drs. Vidyasagar and Nagamani Award for Excellence in Pediatric Critical Care Medicine in association with Society of Critical Care Medicine. So welcome, ma'am. Dr. Suchitra Ranjit, she's senior consultant and head pediatric ICU at Apollo Children's Hospital in Chennai. She was the IAP PIC chairperson 2002 to 2004, VC College of Pediatric Critical Care in 2018, and Asian representative of WFPICCS Board of Directors from July 2020 to June 2022. Welcome, ma'am. And Dr. Saumil Kaur, he's a senior consultant in pediatric nephrology at Rainbow Children's Hospital, Bangalore. He established the pediatric nephrology unit at Rainbow Hospital and started the pediatric kidney transplant program. He heads the fellowship training program along with the DND pediatric training program. He runs the nephrotic clinic, nephro-uro clinic, transplant program, and the nephro ICU clinic at our institution. He has multiple research papers in national and international journals, and he has been the author of chapters in multiple textbooks. So with this, I now request Dr. Jayashree to kindly introduce our first speaker, Dr. Edward Behrens. Over to you, ma'am.
Thank you, Chandrika, for this opportunity. Thank you, Rakshay. And a very good evening to my co-chairs, Dr. Suchitra and Dr. Saumil. And I think, is it good morning to the first speaker, Dr. Edward Behrens, joining us from US, right? Okay. So it gives me immense pleasure to introduce the first speaker of the session, Dr. Edward Behrens, who's the chair of the Division of Rheumatology and the